The human hip is a heavy-duty, weight-bearing hinge. It's a pressurized mechanical junction uniquely susceptible to wear, tear, and catastrophic structural failure. Conditions like osteoarthritis or avascular necrosis slowly destroy this mechanism. Cartilage wears away and bone dies, leaving a grinding hinge. This degradation causes the primary clinical presentation: severely restricted mobility and chronic pain, even at rest. Conversely, sudden trauma like a displaced femoral neck fracture snaps the lever arm connecting leg to pelvis. The clinical picture is immediate. Patients lose weight-bearing ability, mobility drops to zero, and the limb presents with an external rotation deformity. Whether the joint degrades over decades or snaps in a second, the mechanical loss is total. Surgical replacement becomes the only viable clinical path forward. Joint arthroplasty is the surgical reconstruction or physical replacement of that damaged joint with a prosthesis designed to replicate healthy movement. When the socket is intact but the femoral head is fractured, surgeons perform a hemiarthroplasty. This procedure replaces only the broken ball of the joint, anchoring a solid unipolar metal prosthesis directly into the natural femur. A total hip replacement goes further, replacing both femoral head and acetabulum with artificial components for stem, ball, and socket. To ensure safety, the new acetabulum is plastic-lined, preventing severe damage and debris from metal-on-metal articulation. Total replacement is indicated when systemic joint diseases like severe osteoarthritis or rheumatoid arthritis degrade the entire socket structure, not just the femoral head. These metal prostheses completely resolve the mechanical breakdown of the joint. However, placing heavy hardware without original ligamentous support introduces a highly dangerous period of postoperative instability. Before we introduce that trauma, we have to establish the patient's biological baseline. Preoperative screening requires a complete blood count, liver and renal function tests, and a full coagulation profile including PT, APTT, and INR. A blood type and screen is also mandatory. Cutting into the femur and manipulating marrow space guarantees massive hypovolemic blood loss during the procedure. We also have to account for bacteremia. The newly implanted metal hardware is completely avascular, meaning the body's immune cells cannot reach it easily if blood-borne bacteria decide to colonize the surface. This vulnerability dictates a mandatory preoperative dental checkup. Any carious teeth must be extracted to eliminate a direct, highly vascularized pathway for oral bacteria to enter the bloodstream and travel to the hip. To maintain systemic defense, prophylactic antibiotics are administered. This pharmacological cover is the primary way to protect the metal prosthesis from infection during the perioperative window. Every preoperative investigation and intervention serves one purpose: stabilizing the patient's biological environment before introducing massive surgical trauma and foreign material. Once the surgery is complete, the new prosthetic joint is incredibly unstable. It lacks the mature, tight ligamentous tissue capsule holding a natural hip together. The core postoperative nursing objective is mechanical containment. You are actively preventing the patient's leg from acting as a lever that physically pries the new metal ball right out of the socket. This requires strict adherence to hip precautions. Rule 1. Prevent adduction. The operative leg must never cross the midline of the patient's body. The immediate clinical intervention is the application of an abduction pillow positioned directly between the patient's legs while in bed. This dictates the turning protocol. Nurses must only turn the patient as strictly prescribed by the surgeon, ensuring the abduction pillow remains firmly clamped in place during any roll. Rule 2. Prevent extreme rotation. The leg must be maintained in proper neutral alignment without extreme internal or external twisting that could torque hardware. Rule 3. The 90-degree limit. Flexing the hip past 90 degrees creates a direct dislocation vector, forcing the femoral head backward out of the acetabulum. To enforce this, the head of the hospital bed must be strictly locked to a maximum elevation of 45 to 60 degrees for the first 2 to 3 days. Patients must be explicitly instructed to never lean forward in bed. Reaching for objects on the floor, pulling up heavy blankets, or attempting to put on shoes all violate the 90-degree rule. These positioning rules are strict mechanical limits. Breaking them means breaking the joint. Maintaining these rules requires specific assistive devices. Long-handled reachers, grabbers, and long-handled shoehorns allow patients to perform daily tasks without breaking the 90-degree flexion limit. Transfers from the bed to a bedside chair require precise body mechanics. The nurse must assist the patient to the edge of the bed while keeping the operative leg in strict neutral alignment. Once seated, the patient's posture must be actively managed. The knee must remain slightly lower than the operative hip to ensure the joint angle stays wide and safe. The physical action of sitting down must also be controlled. The patient must reach back to grasp the arms of the chair and lower themselves slowly, keeping their torso upright rather than bending forward. During these initial transfers, nurses must monitor for orthostatic hypotension. The combination of blood loss, anesthesia, and bed rest creates a high risk for sudden dizziness and falls. Every basic activity of daily living has to be completely reverse engineered to protect the vulnerable surgical hinge from failure. In the acute post-op phase, monitoring focuses heavily on hemodynamics. The massive blood loss from cutting femur bone creates a severe, ongoing risk of hypovolemic shock. You must also establish strict protocols for assessing peripheral neurovascular dysfunction. This is done by checking the 6 Ps: pain, pulses, pallor, paralysis, paresthesia, and pressure in the affected limb. Surgical site management is the next priority. The deep incision point carries a high risk of impaired tissue integrity and localized infection. A closed drainage system, such as a Retivac drain, is used to actively pull exudate from the surgical site. This prevents hematoma formation and reduces pressure around the new joint. The drain is typically kept in situ and closely monitored for volume and characteristics before being removed on postoperative day 2 or 3. Because the patient is subjected to mandated, highly restricted bed rest, routine skin assessments are necessary to prevent the rapid development of pressure injuries. Nurses must immediately investigate any reports of sudden severe joint pain, intense muscle spasms, or sudden chest pain with dyspnea. Early postoperative vigilance is entirely about detecting hidden hemorrhages, pulmonary emboli, or catastrophic hardware dislocation before they escalate into fatal complications. This leads to the central paradox of arthroplasty nursing. We have to strictly limit the operative hip's movement, but we must simultaneously perform early mobilization to prevent systemic physical decline. Pharmacological interventions are crucial here, but their goals are specific. Analgesics like obelines and NSAIDs provide symptom comfort. They do not cure the underlying tissue trauma. The pain experienced by the patient is immense. It is the direct result of the massive tissue manipulation, muscle cutting, and nerve trauma required to install the prosthesis. The primary pharmacological intervention is administering strong analgesics around the clock for the first 24 hours, often achieved through patient-controlled analgesia or continuous epidural infusions. Timing is critical. Pain medication must be administered and peaking 30 to 45 minutes before physical therapy begins, ensuring the patient can tolerate the session. Early movement is non-negotiable. Without active muscle contraction, severe systemic muscle atrophy sets in rapidly, drastically extending the rehabilitation timeline. To counteract this, nurses must assist the patient with active and passive range of motion exercises on all unaffected joints to maintain overall strength and prevent contractures. Teaching the patient to use an overhead trapeze bar allows them to safely reposition themselves in bed. This builds the crucial arm and shoulder strength they will need for crutches, while keeping the operative hip isolated. Non-pharmacological comfort measures, like maintaining proper leg alignment and applying ice, reduce localized muscle spasms and limit undue tension on the prosthesis. Aggressive preemptive pain management provides the clinical window necessary for the early mobilization that restores function to the newly engineered joint.